All right. So, hi everyone. For those of you I don't know, I'm Megan Koster. I'm one of the third-year pulmonary and critical care fellows. Thank you for all the work that you're doing on service in the MICU. Um, and so today we're going to discuss the acute respiratory distress syndrome, or ARDS. And our goals today will be to explore the pathophysiology of ARDS. We'll review the diagnostic criteria, including categories of mild, moderate, and severe ARDS. And then we'll discuss an initial approach and then troubleshooting mechanical ventilation in ARDS. So to begin, patients who develop severe COVID-19 infection requiring admission to the ICU for hypoxemic respiratory failure do so because they have developed ARDS. Before the pandemic, ARDS accounted for about 10% of ICU admissions and about 23% of mechanically ventilated patients worldwide in an epidemiologic study called LungSafe, which was published in 2016. So, of course, now during the pandemic, as you're likely experiencing, those prevalence numbers are much higher, and we're seeing a lower proportion of non-COVID or non-ARDS ICU admissions. But I bring up LungSafe because it has sort of taught us about what ARDS patients look like and how they fare. So far, epidemiologic data from the pandemic are still emerging, but we do have the largest case series of critically ill COVID patients from Italy, which had 1,500 patients, and that can give us some insight into the characteristics of this population. So in this group, 88% required mechanical ventilation, and they had a 26% ICU mortality rate. And interestingly, the median age, median P to F ratio of about 160, and median FiO2 required in the first 24 hours were all similar to the averages, the medians found in LungSafe. So that had sort of prompted us to think, well, maybe what we're seeing is just what we know, ARDS, just a lot more of it. And then there's newer data, epidemiologic data that came from folks at MGH and BIDMC, so local data. They published about 66 patients who were mechanically ventilated with COVID in March 2020, and they had similar findings. So in their paper, the median P to F ratio was 182, so moderate ARDS, and the median PEEP was 10, and median compliance of the respiratory system was 35. And of these folks, they had a 16% mortality rate, and 62% were extubated. So that some of those numbers are also similar to published trials that have described the compliance and P to F ratios in ARDS. And so it's more support that clinically the ARDS patients are having with COVID looks like the ARDS we're familiar with. So when asked what is ARDS, I think it's really tempting to reach first to diagnostic criteria, but we'll actually spend the next several slides focusing on the pathophysiology of ARDS, which was really has been teased out over after 50 years of basic science and immunology research. So ARDS is a diffuse inflammatory lung injury that disrupts the alveolar and vascular interface. You have an impaired alveolar and vascular epithelium, and that results in profound capillary leak. So this floods the alveolus with non-cardiogenic fluid, inactivates surfactant, and generates an inflammatory cascade that also results in an imbalance of pro and anticoagulants that causes microvascular thrombi. So we'll explore that pathophysiology that I just described visually with this image, which is from an excellent review of ARDS in the New England Journal by our own Taylor Thompson. And so we'll take a deep dive into this process here. So on the left, there is a healthy alveolus, You can see the bronchial epithelium here transition to a single layer of pneumocytes at the edge. There's a layer of surfactant, which reduces their surface tension and keeps the alveolus open. And then in the center here, you have an alveolar macrophage, which is one of the most prevalent immune cells of the lung. And so on the right, this is the first phase of ARDS called the exudative phase. And so in the exudative phase, there is an injury, which is either direct to lung tissue, as could be caused by things like pneumonia, aspiration, a pulmonary contusion, or an inhalational injury, or it can be indirect, which is from inflammation in the rest of the body, so resulting in systemic inflammation driven by things like sepsis or pancreatitis. And that injury results in an inflammatory cascade. Essentially, it's the response to the injury that causes these pathophysiologic changes. So as a consequence of that, the result is disruption of the alveolar epithelium and the vascular endothelium, and this flooding of the interstitium and the alveolus with sort of protein-rich edema fluid. And that precious single layer of pneumocytes is disrupted, and you have flooding of the alveolus. So let's think for a minute about how this process would manifest in our patients. So flooding of the alveolus with fluid would result in wet, stiff lungs. The inactivation of surfactant would result in alveoli that are prone to collapse. And then you can think of microvascular thrombi as increasing pulmonary vascular resistance and worsening dead space. So we'll also explore these concepts by looking graphically at what would happen. So I have two graphs here. On the left is a pressure volume curve of the lung with pressure on the x-axis and volume on the y-axis, which makes the slope of this line the change in volume over the change in pressure, which is compliance. So as the wet lung sort of stiffens, it gets more difficult to inflate. So to make a change in the volume, you have to apply a higher pressure, meaning that stiff ARDS lungs have a low compliance, and that slope goes down and the curve flattens. On the right, we have a graph that you might see on a ventilator screen. So this shows the pressure at the airway opening versus time. And I've labeled the pressures over this sort of pink tracing as the pressure before the breath is delivered is the PEEP. That's the pressure at the end of the last breath. And then once the breath begins, the pressure rises to a peak. So the PIP is the peak inspiratory pressure. If we were to do an inspiratory pause here at the purple arrow, then flow would stop. And so the pressure that's dissipated by resistance would go to zero, leaving the plateau pressure, which we had previously talked about as imagining the plateau pressure as the distending pressure of the lung. And the difference between the plateau pressure and the PEEP is called the driving pressure. So this is the relevant change in pressure that we use to calculate compliance, just as a review from the talk, I think on Friday with Dr. Hibbert. And so as the lung stiffens and compliance falls, the driving pressure increases. Does this make sense, everyone? Any questions on this? Okay. So ARDS is a syndrome of phases. We've already talked about the first phase, the exudative phase, and how we might observe that physiology on the ventilator, but now we'll explore sort of two additional phases. So the next phase is the proliferative phase. So this generally occurs at 7 to 10 days, and it encompasses the lung's reparative processes. So the type 2 pneumocyte over here is a stem cell, which can repopulate both the type 1, sort of single layer pneumocyte, and itself, sort of the type 2 pneumocyte populations, and that restores an effective barrier function. Fibroblasts proliferate as well, and these reestablish the interstitial matrix, and there is resorption of that protein-rich edema fluid and drainage via the pulmonary lymphatics. In a subset of patients, this process goes awry, so leading to the fibrotic phase of ARDS. So in these patients, there is extensive fibroblast proliferation. It's not transient, and it results in excess deposition of collagen, which leads to fibrosis of both the interstitial and interalveolar spaces. These patients, unfortunately, often have a prolonged need for mechanical ventilation and tracheostomy. And they may not have restoration of normal lung function after their ARDS. So the pathophysiology that we've just reviewed has informed the development of the diagnostic criteria for ARDS. So there's no established biomarkers for identification of ARDS, so we rely on defining ARDS as a syndrome. So this table is the Berlin definition of ARDS, which was updated in 2012. And this displays sort of the components of that definition. So we'll take it from the top and describe. So the first is timing. So the timing is described as an onset of symptoms within 1 week of a clinical insult, with chest imaging that demonstrates bilateral opacities, otherwise consistent with pulmonary edema, but not fully explained by pleural effusions, collapse, pulmonary nodules or masses, and not fully explained by heart failure. The last criteria hinges upon hypoxemia. So patients must have a P to F ratio, which is their PaO2 divided by the FiO2 as a decimal, of 300 or less on at least 5 of PEEP. So the lower the P to F ratio, the more hypoxemic you are, and that indicates the severity of the disease. So here's an example of a set of radiographs which were included in the initial publication of the Berlin criteria, and it highlights that there's a range in what qualifies as bilateral opacities that would be consistent with pulmonary edema. So you can see here of these 3 films, they all look a little bit different. This one in the center has more extensive disease on the right than the left. In the film that's on the left, you can see that this disease is quite heterogeneous, so all lobes are affected, but to varying degrees. And that should remind us that when we're applying ventilator strategies to oxygenate and ventilate a person with these lungs, we have to remember that different lung units are going to be affected differently by the disease, and so are experiencing different volumes and pressures. Okay, so one other commentary on hypoxia in the diagnostic criteria for ARDS. So why do we care so much about the P to F ratio? So I reviewed that that in order to sort of have the Berlin criteria, in order to meet that criteria, your P to F ratio has to be less than 300. And then the categories of disease is mild as 200 to 300, moderate of 100 to 200, and severe as less than 100. These were chosen through a validation process. So what that means is that the Berlin authors applied this criteria to a meta-analysis with data from over 4,000 patients with ARDS, and the categories chosen were able to predict non-overlapping mortality rates in that group of 4,000 patients. So this is why that we say the P to F is predictive of mortality, because patients who had a P to F ratio in this range had a resultant mortality of 45%, for example, with severe disease. And then the other reason that we care is that many clinical trials of therapeutics in ARDS, including paralysis and proning, were performed in patients who had moderate to severe disease. So in that way, we can use the P to F ratio to compare our patient to the study population. Okay. So lastly, we'll move from diagnosis to treatment. So in patients with ARDS requiring mechanical ventilation, the goal is to use the ventilator to improve oxygenation while minimizing ventilator-induced lung injury. So mechanical ventilation essentially provides the supportive care needed while we treat the underlying problem, or if we don't have specific treatments for that problem, we allow the lungs reparative processes to take place. So the cornerstone of ARDS management is lung protective or low tidal volume ventilation. And the reason for this emphasis on low tidal volume ventilation is quite simply that it saves lives. So this graph is from, this graph depicts the key results from the ARMA trial, which was published in 2000, that really established this mortality benefit. So ARMA had over 800 patients with ARDS and a P to F ratio of less than 300, and they compared two groups. So one group had traditional tidal volumes that ranged from 12 to 15 cc's per kilo, and one with low tidal volumes of 4 to 6 cc's per kilo of ideal body weight. And you can see from this graph that survival at 180 days was significantly higher in the low tidal volume ventilation group than the traditional tidal volume group. But how do we achieve that in our patients? So even if you're not the ones deciding on the initial settings, when you assume care for a mechanically ventilated patient with ARDS, you should review their vent settings to make sure they align with these parameters. So first, we typically use a volume control mode because that allows us to set the tidal volumes, and we also set the respiratory rate, FiO2, and PEEP. The tidal volume should be 4 to 6 cc's per kilogram of ideal body weight, which again depends on your patient's gender and height. And so this is something that I always double check. We're very spoiled here because respiratory does such a wonderful job, but I always double check because some very tall patients will have larger allowed tidal volumes, but very small patients actually need quite a bit less. So next, you choose an initial respiratory rate for a goal minute ventilation. So remembering that the minute ventilation is the tidal volume times the respiratory rate, and a normal minute ventilation is between 5 and 8 liters per minute. And that might be increased due to certain conditions, including hypercarbia. And then you set the FiO2 and PEEP. So we'll review how to choose a PEEP and an FiO2 in the next lecture. But I'll point out here that we sort of titrate these to a goal oxygenation of a PaO2 between 55 and 80. So we haven't quite committed to evidence that a higher PaO2 outside of that range is better. Or you can also use an oxygen saturation of 88 to 95% if you don't have an arterial line. So then the dependent variables are the pressures. So in the settings above, we monitor for the plateau pressure with a goal to keep that under 30, and then we monitor the driving pressure. So again, that difference between the plateau and the peak, to keep that under 15, because there's some retrospective data that driving pressure less than 15 is associated with lower mortality. And lastly, because we're using low tidal volumes, we also have to monitor the pH and the PCO2, our blood gas. There's two common issues we encounter with low tidal volume ventilation. The first is hypercarbia. So remembering that tidal volume and respiratory rate are the parameters that control ventilation in our patients, which is the clearance of CO2. So as CO2 accumulates, the pH of the blood will fall, and this will cause a respiratory acidosis. I'm sure you've heard the term permissive hypercarbia, which is the practice of allowing the PCO2 to be above the normal range just to facilitate using low tidal volumes. But if the patient develops a respiratory acidosis such that the pH is below 7.2, we can adjust the ventilator to fix that. So first, we'd increase the respiratory rate, even going up to 32 or 35. and then liberalizing the tidal volumes if necessary. The second is sedation. So remember, spontaneously breathing patients typically take in tidal volumes of 7 to 8 cc's per kilo, but patients who are in respiratory distress or hypercarbic will have a really strong respiratory drive and may even be taking tidal volumes larger than that. And this can make it hard for them to tolerate low tidal volume ventilation. So we'll have a whole lecture dedicated to sedation. But just a reminder here that opiates in particular are a core component of this regimen because they provide both analgesia and they also decrease the respiratory drive. And then there's a whole toolkit of adjunctive treatments that we're going to explore in additional lectures. But just to say that in addition to low tidal volumes, we're going to use this toolkit. So including conservative fluid management after the appropriate resuscitation, optimizing the PEEP, which can be done by myriad ways, and no data demonstrating superiority of one method over another, but at our institution, commonly used techniques include either using the low PEEP table from the ARDSNet group or selecting the PEEP by best tidal compliance. Prone positioning, which has a demonstrated mortality benefit in moderate to severe ARDS, paralysis with neuromuscular blockade to achieve synchrony, pulmonary vasodilators, which again have been shown to improve hypoxia, but have not demonstrated a mortality benefit in all comers. And then as a last option, VV ECMO if other options have failed. So I'll pause here for any questions that you guys have.
I don't think we have any questions right now, Megan, but thanks so much. That was awesome.
Okay. All right, you guys can definitely reach out to me if you if anything comes up. You guys are doing great work in the MICU, as I observed this past weekend. And take care. Again, feel free to reach out with any questions.
Thanks so much.